Welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, May the 21st. So coming up on a nice long holiday weekend. We're looking forward to that. So let's go ahead and do some quick introductions. On the call with me today, got a good little group joining us today from the STS side of things. We've got myself and Carol Crone, Emily Conrad, we have Melinda, Paul, Banu. From our CHSD consultant sides, we have Chastity and Leslie. And then we have a new face joining us today. We have Nancy Honeycutt, and she is the new STS Adult Cardiac and Intermax Database Manager. So welcome to Nancy. For her first, I believe this is your first congenital webinar joining us today. So welcome, Nancy, welcome to the team. We're happy to have her on the STS side of things. So let's go ahead and hop into today's agenda. I'm going to provide a brief STS update, and then I'll turn things over to Chastity and Leslie, and then we'll finish things up with our Q&A. As a reminder to please submit your questions via the Q&A. We're going to go ahead and turn the chat off. So again, please be sure to submit your questions via the Q&A function. We also have the raised hand function enabled. So if you would like to ask a question, please be sure to raise your hand and ensure that your microphone is enabled on your side. All right, let's hop into our STS updates. The May training manual is posted and available out on the STS website. For spring 24 harvest, as you all are aware that the surgery dates included in that spring 24 harvest include the time frame of January 1, 2020 through December 31st of 2023. The STS analysis team has completed the analysis, and the data has been sent over to IQVIA, and they are working on uploading the data into the platform. Unfortunately, we have not had a meeting with them this week, so I've not gotten an update on when that data will be available. But as soon as I have more information on the report availability, I'll share that with you all as soon as possible. Just know that once IQVIA does have the data uploaded into the platform, we'll be doing a considerable amount of QC for this report, since this will be the first time that we are reporting out 6.23.2 data. So we will be taking our time doing that QC, very thorough QC. And again, I will share more information on the report availability once I know more from IQVIA. The fall 24 harvest is currently underway, so I know sites are submitting data for the fall 24 harvest. That fall 24 harvest will include surgery dates of July 1, 2020 through June 3rd, not June 3rd, that should be June 30th of 2024. I'll get that updated. And that harvest for the fall 24 is scheduled to close on September the 27th at 11:59 p.m. Eastern. Regarding the fall 24 harvest, if you have submitted data or if you have not submitted data, we want to make you aware of a new NPI validation for sites that are using third-party vendor software. So this new NPI validation ensures that only cases for surgeons or anesthesiologists on your contact list are accepted into the database. If a case is uploaded for a physician not on your contact list, that record will fire a critical error, and that record will not be accepted into the database. We did send an official communication to participants about this new NPI validation on May 10th. So again, that official communication for this new validation was sent out on May the 10th. We ask prior to your next upload, we ask that you review your contact list to verify that the surgeons and anesthesiologists STS has on file, to verify the surgeons and anesthesiologists that are currently on file with STS. You can review your contact list within the IQVIA platform. You can access that list. It's located under the operational reports. So again, you can access that contact list within the IQVIA platform under the operational reports. If you find that any of your surgeons or anesthesiologists are missing from STS's records, please complete the required documentation. It is a contractual requirement and must be done as physicians join your site. So once a physician joins your site, you are contractually required and obligated to submit a Schedule A for that surgeon or Schedule B if it's an anesthesiologist. So you are required to update their contact form, submit that Schedule A or Schedule B to STS once a new physician joins your site. If you have any questions about the NPI validation or updating contact information, please reach out to us via the STS help desk, and we can address any questions or anything that you have regarding updating contacts or submitting Schedule A's and Schedule B's for your site. Again, just the standard harvest schedule slide. Again, the fall 24 harvest is scheduled to close September 27th with an opt-out of October the 1st. Just a friendly reminder, AQO is coming soon, September 11th through the 13th in Nashville, Tennessee. The congenital session will be held on Friday, September 13th at Lowe's Nashville Hotel at Vanderbilt Plaza. So we are looking forward to everyone that is going to be joining us in person. If you're not joining us in person, we're looking forward to you joining us virtual. So again, AQO is scheduled for September 11th through the 13th. AQO registration is now open. So again, we encourage you to register and reserve your housing as soon as possible. Also, we are now accepting abstract submissions for AQO 2024. So to submit an abstract, we have a link here that is available out on the AQO website as well. Abstract submission opened actually yesterday, Monday, May 20th, and abstract submission close date is scheduled for Monday, June the 24th. I believe an official communication is coming out soon. We'll be sending an official communication, Emily, to everyone. Okay.
Yep. There'll probably be an email that goes out to all primary and backup data managers. And then we'll put something in the STS news and the database news. Weekly, or I'm sorry, STS weekly, I believe, and then STS database news.
Perfect. Thanks, Emily. So, so if you have any questions, please feel free to reach out to us. And again, AQO call for abstracts opened yesterday, Monday, May 20th, and is scheduled to close on Monday, June the 24th. So please get those abstracts in. We'd love to have them included AQO this year. Again, just our pricing for AQO, the early bird discount did end on May 16th, and now we have our standard rate. So again, we have our in-person pricing as well as our virtual pricing. And all of this information can be found out on the STS website and the AQO page. And that's all that I have regarding the STS updates. Next, I'm going to turn things over to Chastity and Leslie. They have a lot of information to get through today. So Chas, Leslie, I'm not sure who's starting first. I think it's Leslie.
Yep.
I'm going to turn it over to you.
Okay, great. Thanks, Leah. Thank you so much for all of those wonderful updates. We're going to jump right in because we do have a fair number of slides to cover today. So first, we just wanted to give a quick audit update. This is in regards to the update we made starting with January 1st cases and regarding counting prior cardiac operations. And this is only going to apply to how this field is audited, not how we're collecting it. But going forward, or when the audit starts to include 2024 cases, they will only be considering 0 or greater than 0, which aligns with how the risk model looks as well, not the specific number. So if your patient had 4 prior operations, you've entered 4, the auditor comes and looks, but they see 5. They're just looking to make sure you either got 0 right or that the number was greater than 0. Again, this does not change how the data is collected. And for more information on how to actually collect that field with that change, you can revisit the November 7th webinar. And actually, I just misspoke. this is not just for 2024 cases. This is how they will be auditing this field regardless, but just keep in mind that this change occurred for cases after January 1st. Okay, next slide. Just wanted to give a few updates regarding our FAQ mailbox. We were losing a fair number of congenital FAQs that were submitted specifically to the anesthesia mailbox. We're not really sure how, but we did work with the team to reduce the number of congenital options under the clinical question submission form. So now you're just going to pick between version 6.23 and version 3.41 if you're working on an older case. Just a reminder that if your question is time sensitive, especially as we get close to harvest closes, please indicate that in the text box and kind of prioritize that if necessary. And then just as always, we always hope to respond within 30 days, but we are noticing sort of this like roller coaster, I guess, with questions submitted. I think everyone was sort of focused on harvest, so we had not a lot of FAQs come in, and then once people got back to collecting current data, we have now had an onslaught, so much so that we actually have 2 core calls this month to get through them all. Next slide. And then just so that you know, there are other options to getting some of your questions answered. Of course, submitting an FAQ specifically for anything clinical. If you need to have us review an op note, something like that, you're welcome to ask Q&A during these webinars as well. That is especially helpful for like workflow kind of questions. Phone a friend, find another data manager who might have the same vendor or a similar size program as you do, or who does, you know, a similar case mix. And then utilizing the EDDI group. That's just asterisk because we know that's not an STS call, official call. So it's a great way to network and find a friend or go through like, hey, how do you do this? But just keep in mind that those answers are not official. And so if it does make a difference with a field or how you're collecting data, it needs to be something submitted through the FAQ for an official response so that it's usable should an audit occur. Next slide, thank you. So this was just our map. I actually did this a couple of years ago, but to sort of give an outline of how FAQs work. So once the question is submitted online, sometimes Chastity and she and I meet weekly to kind of review the questions that are in there and anything we can answer right away. So sometimes we can get back to you right away. Other times we may not be the correct team to answer the question. So we might need to include a larger group, like someone in the research center or about contracts or anesthesia. There should be a little bubble for adult. We often send some questions over to Melinda to kind of get her opinion before we figure out how it works with congenital patients. If we do have all the right, or if we are the right team to answer the question, then we need to make sure we have all the correct information. So we might communicate with you about sending an op note or giving us a little bit more information before we review the question in full. We also go through the specs document, the training manual, old training manuals, and talk to the core group during our meeting. And then we will send official responses from the FAQ mailbox. At that time also, we'll update the training manual if it's necessary with like some extra clarifications or examples. We may have to go to the task force if there's like a bigger question or a process change on the horizon. It could involve editing code and logic on the IQVIA or analysis side. Or a lot of times we just make a note for the next version upgrade if we need to create a new field or provide more options or something like that. Okay, next slide. And then we were noticing this month that we had a number of frequently asked questions. We had a lot of the same questions coming in, so we just wanted to touch on a few of those since we were seeing them more often, more than just one time this month. So our first one is a stretched or enlarged PFO considered an ASD? Next slide. No, enlarging or stretching a PFO does not make it an ASD. This is just sort of once a PFO, always a PFO. So you'll use that appropriate diagnosis and procedure. Next slide. Do I have to use both the combination code and the individual procedure codes? Yes. We highly, highly encourage sites to use both the combination codes or a number of combination codes, as well as all of the individual procedure codes that make up that combination. And this is for many reasons. Number one, it ensures that the most appropriate procedure code is going to be selected. So because it could qualify for more than one combination, if we have all of those individual procedures in the list, the algorithm can select the most appropriate and the most, highest stat score, or however it fits into the rules and exceptions. And then if any codes are updated in the future, the component procedures will already be listed. So then that logic is there. Those codes are there for the logic to then apply to. And that has happened in the past. If you remember, we've updated the procedures that go into like our stage 2 combo procedures. And then also it further delineates the surgical details and therefore aids in research, or if we are, doing QA work on the data that comes in, we have a little bit more detail then if we can see all of the procedures that go into those combinations. Next slide. Can I use a combination code that is close to the procedure performed? For example, my surgeon completed a VSD repair patch and an ASD repair patch, and they want to use the combination code 5001. Next slide. No. Combination codes were derived through research and are only applicable to the specific procedure code. So 5001 does not apply to fixing both of those lesions with patches. It's just code 110 and code 20. Next slide. And just as a reminder, all of the details that go into our combination codes, including the specific procedures that make up, are listed in the analysis overview, which can be found on the website. And next slide. And also in the training manual, each combination code that's listed, we have written out exactly which components are included. Next slide. Okay, do I have to select operative mortality for each event, or can I use this to indicate mortality assignment? Next slide. Yes, mortality assignment, sorry, that's 2 questions and I just said 1 answer. Yes and no. Mortality assignment is a retired field. We no longer have that as part of the database. Operative mortality includes all deaths, regardless of cause, occurring during the hospitalization in which the operation was performed, even if after 30 days, and all deaths, regardless of cause, occurring after discharge from the hospital before the end of the 30th postoperative day. So it's every event which occurs in that time frame. Next slide. Again, this can be found in the training manual. It goes into the details, and this is regardless of index, non-index. It has nothing to do with op type. It's everything that qualifies when the patient dies. Next slide. Okay, can I capture intra and postoperative events on any case? Yes, but next slide. There are some things to consider. So the first thing is whether or not this is an index case. Is it an index case or a non-index case? And that's because all intra and postoperative events are collated to the index operation of the patient's episode of care at analysis. So you can capture events on the surgery that makes the most sense or is most closely related to the event, but it's very important to understand that at analysis, all of those events are attached to the index, or like when we report those out in the feedback reports. Next slide. And just again for definitions for things like index operation in the training manual, starting on page 6, I believe there's a definitions section. So index operation is there. And as a reminder, it is the first cardiac, CPB, or no CPB cardiovascular operation of the patient's episode of care. Next slide. Some other things to consider. So if it is the index operation, then yes, capture away, capture everything that's applicable. Next slide. But if it's a non-index case, you need to know if the case occurs prior to the true index operation. All events go to the index operation. Therefore, if you capture events, post-operative events or intraoperative events on a surgery which occurs pre-operative to the index, those will also then get attributed to the index operation, which we do not want. So instead, you will capture those things that happen pre-operatively if they're appropriate in the preoperative factors section of the index operation. I know this is confusing, so let's go through an example. I think that slide is coming up. Yep, okay. Patient arrives at your hospital in shock and requires ECMO emergently by your cardiac surgeon. The patient further declines, has cardiac arrest, and is taken to the OR for surgery on bypass. Next slide. So this first one, it's an ECMO case done emergently by your cardiac surgeon. So you are going to enter this in the database as an ECMO cannulation, but you will not capture any intra or postoperative events on this record. Next slide. The patient further declines, has a cardiac arrest, and is taken to the OR for surgery on bypass. So that being on bypass is going to be your index operation. And you can, of course, enter those preoperative factors. So shock, ECMO, cardiac arrest, whatever else is applicable in the preoperative factor section, and then any intra and postoperative events occurring after that OR entry date and time. Next slide. Okay, that's it for me. Off the chest.
Okay, excellent, Leslie. Thank you very much. So the one thing I want to focus on today, after Leslie gave her banner presentation over many topics, is the infamous topic of our systemic versus non-systemic AV valve. So as you know, in this version, we've changed how we were collecting valve-related diagnoses and procedures. So I pulled in some pictures here from the data collection form showing that when it comes to systemic versus non-systemic AV valves, we're very much focused on the tricuspid or non-systemic AV valve, or the mitral or systemic AV valve. Next slide. So in version 6.23.2, we have now changed that in saying that valve-related diagnoses and procedures are to be captured based on their valve function. And so what we're going to review today is just the systemic versus non-systemic AV valve. So again, based on their function, this may be very different than what you see in your op notes. So hopefully I can give you some clarity and some examples. Next slide. Okay, so let's look at what AV valves are. So these are the valves simply, not in all of our good congenital hearts, but simply that separate the atria from the ventricles. And I provided a picture here. So our two AV valves are the mitral valve and the tricuspid valve. So which of these then in a normal heart would be the systemic valve? It's the valve that is supporting the systemic circulation or the blood flow to the body. And so that, of course, in a normal heart is the mitral valve. So the non-systemic AV valve is the valve then that is not providing systemic support to the body. And a normal heart would be what's providing the pulmonary blood flow. Now, of course, we're operating on hearts that are not normal. And so we just have to be able to determine which valve is providing the systemic support or systemic circulation. Next slide. So as I was saying, there are congenital heart defects where the systemic support is provided actually by that tricuspid valve. And this is where it gets really confusing. All of our surgeons are going to dictate this differently. And it may even be like within your program, if you have multiple surgeons, that they in turn dictate the valves and where they're located differently. And so I included a picture here, and this is congenitally corrected TGA, and you can see if you look at the diagram, number 4 is your tricuspid valve, and it is providing the systemic support out to the body. Number 1 being the right ventricle. And so you see that in this lesion set where that is the tricuspid valve on the opposite side of the heart is providing the systemic support out to the body. So this would be a case where your systemic ventricle is actually your tricuspid valve. Your surgeons or ECMOs or echocardiographers or cardiology, ICU, whoever is dictating your notes, you may find that they all, depending on where they trained or how they function today, may call that valve all kinds of different things. And so unfortunately, it's our jobs to try to figure out which valve is correct. It makes a difference in the database if we've done a procedure on the systemic or the non-systemic AV valve. Next slide. And so this is a picture of a normal heart versus HLHS, where of course you have mitral valve atresia. And with mitral atresia, that means your tricuspid valve over the course, even at functionality, looking at it before it's repaired. And then as you go on down your repair pathway for this lesion, the tricuspid valve again is going to serve as your systemic AV valve. Next slide. So what do I do if the valve that is providing that systemic support, my surgeon is dictating the op note to say tricuspid valve, tricuspid valve? It's true, and it may be exactly how they dictate. And so we have to be smarter than our surgeons. I think for me, when I personally look at these, I try to understand the underlying defect of the patient. And most of the time where the tricuspid valve is providing that systemic support, we're looking at single ventricle entities and maybe some other complex congenital heart defects that are not necessarily single ventricles, as in our congenitally corrected transposition. I think the best thing that you can do is work with your surgeon to determine which valve or the procedure done on the valve is providing systemic support or not. I think if you partner with your surgeon on this, their dictation will likely get more clear and help you, as well as I think it's just a good way to partner with them to make sure you're accurately capturing the procedures that are being done on the appropriate valve. And of course, it makes sense that we're capturing the correct valve, but also there are combination procedures where it matters if the procedure was done on the systemic, non-systemic AV valve, and not simply by just always coding it as the tricuspid valve. And of course, you can always submit questions to the core group and submit a de-identified op note to us as well. And we're very happy to go through this with you. Next slide. So I want to give a few examples and a shout out to my own data manager, Linda, who is on this call, where we beat our heads against the wall against some of this. So an example, we have a patient with congenitally corrected transposition of the great arteries with a VSD, and they undergo repair with a VSD patch closure and AV valvuloplasty. So that's how, you know, our op note read at the top. And so then you're like, okay, so which AV valve are we speaking of? And so then when we get into the body of the op note, our surgeon dictated the following. I inspected the tricuspid valve, which was in the systemic ventricle, and noted several chordal attachments impacting the leaflets of the tricuspid valve. They were removed, freeing up the leaflets of the valve. So based on all the information I gave to you, which of the following correctly captures the valve-related procedure? Is it valvuloplasty tricuspid or non-systemic AV valve, or is it valvuloplasty mitral or systemic AV valve? So next slide, Leanne. Hopefully everybody was looking at that it was the mitral or systemic AV valve, because in this lesion, in congenitally corrected TGA, we know that the tricuspid valve is going to serve as the systemic valve based on where it's located in the heart and the function within the heart. One way that when Linda and I looked at this case, that we were able to determine this was that our surgeon nicely stated that the tricuspid valve is located within the systemic ventricle. And so the valves and the ventricles go together, which is a beautiful thing that Leslie from the University of Michigan always puts out and reminds me when we're looking at these cases. And so that was a very good thing when, you know, the surgeon dictated this, that we felt very comfortable going ahead and selecting the mitral or systemic AV valve. And so it's different. It's different than how we've coded before. And it, you know, the surgeon keeps dictating tricuspid, but really it's the systemic AV valve that they intervened upon. And so again, she did for us. That was great. We loved this, but definitely gave us pause, and we definitely had to talk about it and enter the procedure correctly. Next slide. So another example is a patient with single ventricle mitral atresia and undergoes main PA banding, PDA closure, tricuspid valvuloplasty, and an atrial septectomy. So which of the following captures the valve procedure? Again, is it valvuloplasty tricuspid or non-systemic AV valve? Or is it valvuloplasty mitral or systemic AV valve? Correct. So, well, correct, because I checked the box, right? But so this patient has mitral atresia. So we're not intervening necessarily on the mitral valve, but this means that the tricuspid valve is our systemic AV valve. It's going to have to provide the support out to the body. And so again, we're checking valvuloplasty mitral or systemic AV valve. And I know it's hard to do because you're seeing tricuspid everywhere, but the point is we're looking at the function of the valve, and this tricuspid valve is functioning as the systemic AV valve. So next slide. That may be it for me. Yep. Thank you very much.
Yep. Thanks, Chastity and Leslie. I know we do have some questions coming in, so let's go ahead and hop into our questions. And of course, please submit those questions via the Q&A function. And I'm sorry, Jocelyn, I did not see your hand raised until towards the end of the presentation here, so I apologize. So I'm going to unmute you if you wanted to go ahead and ask your question, because I think your question was from earlier on in the presentation. So again, I apologize.
I think I just hit the wrong button. I didn't
Oh,
know.
okay.
Sorry.
Oh,
Thank you.
Oh, no, no worries. It's good to hear your voice either way.
No.
All right, thank you. All righty. So our first question from Melissa, for an anesthesia provider who staffs a single case, but does not typically work cardiac cases, how should a center manage that single case? I don't know if Chas, Leslie, if you guys have any of that experience with.
Personally, if we're gonna collect the anesthesia data for the case, then we would add the anesthesia provider to our Schedule B. Because inevitably, if they do one case, they're gonna come and do a second case someday, or an emergent case later, is what I found as well.
Right.
We
Yeah.
think collecting the data is more important than we wouldn't want the case excluded from anesthesia.
Right. Correct. Let's see here, and we have recently had locum anesthesiologists. Will they all need to sign a Schedule B for their period with the hospital, or how should we manage those instances?
Yeah.
Same answer.
Yep.
Same, yeah, I was gonna say same answer.
If you
Yep.
wanna have the anesthesia, your
Anesthesia.
anesthesia data included on these cases, then they're gonna need to sign the Schedule B.
Yep, agree.
Well, actually, if you want the case included, you got to get them to sign the Schedule B. If you're participating in the anesthesia section and you have an anesthesiologist identified on there, they have to have signed. We're not allowed to touch the data unless we have a signature from the surgeons and anesthesiologists. So that's why we have this check in place. So they all have to be there. Otherwise, we have to kick out the case.
Thank you, Paul. Chas.
Mhm.
Next question from Jen. Are you still responding to the FAQ via email with the answer? Or are they only added to the FAQ document on the website? I have not gotten a response on the FAQs submitted this year.
Yep. Thanks, Jen. So I found 4 FAQs from you in 2024. 3 have gone to this mystery anesthesia mailbox. So I'll go through those today and either answer them or get them to the appropriate people. And then it looks like there's another one that I do have the response sent from. That was in January. So if you need me to forward that one, I can. Otherwise, I will look at the other 3 and get back to you.
Great. Thank you, Leslie.
Yep.
All right, Kelly, when will the CHSD analysis overview be updated to reflect the change in combo code 2330 to remove the tricuspid valvuloplasty 460? So the analysis overview, we are actually working on the updates for that, and that overview will be released just prior to the report release. So you'll see in the analysis overview with the combination codes, what I've done is I have some of those where we've made updates like that. I have some of the combo codes, you know, the procedures listed for the combo code that's applicable for version 341. And then you'll see also right underneath it the same combo code with the procedures that are applicable for version 623.2 forward. So that overview will be released just prior to the harvest report release. All right, let's see here. Next question from Kelly, referring back to capturing complications on the non-index case. If it occurs prior to an index case, will that also include VAD cases?
Great question, Kelly. So yes, a VAD case, if it's op-type VAD with or without CPB, is not going to be considered an index case. So if the VAD was prior to a transplant, which will be your index, do not code those events, those complications or intraoperative events on the VAD event itself, because it would get lumped in with those, with the transplant events. If you otherwise, like lots of sites like to collect complications, post-operative events on cases like that. Like if a patient only comes to your hospital, goes on ECMO, gets a VAD, and then goes home, and you want to collect those events for just local use or record keeping, that is totally fine. You just have to know if there's an index operation, you cannot code those events prior to the index operation.
Thank you. All right, from Kathy. Does it matter what case complications get assigned to when there are multiple surgeons? Do they all get smushed to the patient as a whole when submitted?
Good question. I love that word smushed. They do
I
all get
do.
smushed to
Look at you.
just to the event. So it doesn't, they're not really attributed to a surgeon specifically. It
Right.
would be, you know, the primary surgeon of whatever the index operation was, but they do all get smooshed together.
I like that too. All right, next question from Liz. Will STS update the procedure to 3330 if 460 tricuspid valvuloplasty is chosen with patients that have diagnosis of HLHS with mitral atresia in the analysis?
I'm trying, are you saying will STS make the combination code for you?
Yeah, that's a,
If you have the individual components of a combination field listed, yes, upon analysis, then they will create the combination
Good
procedure for you, as well as IQVIA would give you a mismatch in the report to say you didn't choose a combination code when you have the individual components listed. But if you are asking if STS will otherwise change your data based on your diagnoses, no. So maybe I need a little bit more information, Liz, on your question to make sure I'm answering you correctly.
thanks, Jess. Another question from a different Liz. I need a little more clarification. If a VAD patient has, for example, a stroke before transplant, wouldn't I code that on the VAD implant counter?
On the bad implant counter. If you're talking about the intra postoperative event capture, then you will not code it as a postoperative stroke on the VAD event. You would count it as a stroke in the preoperative risk factors on the transplant. Is that what you're after? Or did I miss the? I hope that's it.
Yeah,
Okay.
that's it. Cool. Perfect. Good job. All right. I'm not seeing any additional questions, but in the meantime, while have a feeling someone's probably typing something, as that always happens. Just really quickly, our next upcoming monthly webinars, I've got the dates listed here for the next 3 months. So our next webinar is scheduled for June 18th. Followed by our July 16th webinar, and then followed up in August, we'll have our monthly webinar on 8/20. So again, our upcoming webinars include June 18th, July 16th, and August the 20th. I also wanted to point out, in case anyone has had or is curious, have not been out to look for your contact update list. For those of you not familiar, I'm just going to pick 50,000, this participant ID here. So again, within the IQVIA platform, if you go under operational reports, and under the operational reports, you'll see here down at the very bottom, your contact list report. So just click this link here. I'm not going to click on it here. But just click this link here and that'll provide your contact list for you. So you can check to ensure all of your surgeons and anesthesiologists are currently on file for your site. Next question from Aaron, is the information about not coding events in a non-index case in the FAQs or manual?
Not in the FAQs, but I believe the training manual in the postoperative events section.
Mm-hmm.
I don't know the page number. I have to double check.
I can pull it up if you need me to. All right. And also, in case anyone did not notice, Emily did include the link for the submit abstracts in the webinar chat. So that link is there as well. Also, we can, if you need information, if you're not sure how to get to the the AQO information, if you go to our STS website, I just go via education, calendar of events, and I just scroll down, which is good. You can see all of the upcoming, all of the events that STS has on the agenda. I just scroll down to advances in quality and outcomes, and that takes you to our AQO page. And all of the AQO information is located here. Registration, reserve housing, then our link to submit an abstract. Also, if you need a justification letter, there is also a link for requesting a justification letter as well. Did I pass it, Emily? Yes, there it is right here.
Yeah.
So it's right here at the top. So request justification letter here. So again, all information is located there. Alrighty, I knew we would get some more questions, so here we go. So not a question, but from Robin, thank you so much for the explanations and the anatomy diagrams on the call, very helpful. And this, of course, this webinar and all the slide deck will be posted. So as soon as the webinar is over, we'll send the link to the recording over to our marketing team as well as the slide deck. And hopefully that'll get posted hopefully by the end of this week, the marketing will have everything posted. Liz, I see that you had a question. So I think
Hi.
I'm gonna unmute. Yes, hi
Can you
Liz.
hear me?
Yes,
Hi.
ma'am.
I was just gonna go back to my question about the combination for 2330. So 460, the tricuspid valvuloplasty is not part of that combination, but based on what was discussed during this webinar, that if a patient has hypoplastic left heart syndrome and has mitral atresia, that the tricuspid valvuloplasty is the systemic ventricle or the systemic valve. So how does STS analyze that if that's the case for the patients that have hypoplastic left heart syndrome with mitral atresia, that the code was selected as tricuspid valvuloplasty instead of the 830 systemic valve?
So Liz, STS will not change your data. You had to have coded the systemic AV valve. Now in previous versions in 341, you can't do this. It is what it is. But in
or it was
623,
included actually. 460
Sorry.
was included in version 3.41. 460 was included. So they
Correct.
excluded.
Yeah, that's fine. But moving forward, you had to have coded that the procedure occurred on the correct valve. STS isn't going to look at that and say, oh, you must have meant.
Well, they had a mitral
systemic
atresia, so this must be the systemic valve,
Nope.
right? Okay.
Nope,
I
they're
just
not
wanted
going
to
to do
make
that.
sure.
You had to have coded the tricuspid valvuloplasty if it occurred
As
on
the systemic, which would
as
be the code
systemic AV.
830.
Yep.
Okay, thank you. I appreciate that. I appreciate the
You're welcome.
clarification.
It's difficult. Like, these are not easy.
Yeah, thank you.
And there are cases where just because you're a functional single ventricle, perhaps you do have a systemic and non-systemic AV valve, and perhaps they do intervene on the other valve, the non-systemic valve. And so that's where STS won't change your data.
Thank you, Liz. Thanks, Chas. All right. Next question from Nancy regarding insurance. How granular do we need to be? For instance, there are many Medicaid plans. Can we just put Medicaid in the state, or do we need group numbers and addresses?
Leanne, I can take that one.
Sure, go ahead.
So for insurance, the STS field itself is just the type. So it would just be okay to list Medicaid. If you have all of those extra fields, it could be specific to your vendors just offering that to you if you want to track it. But for STS specifically, the only thing required is the type of insurance.
Perfect. Next question from Kate. Do we leave the post-op events blank for those non-index cases?
Great question. So you can select no applicable events as one of the options, so it's not blank and you don't get missing fields in your report. But importantly, if you want to collect events on non-index cases and they occur after the index, that's still totally fine. This is only in those rare instances where you have a non-index event that occurs prior to an index.
Excellent. Thank you. All right, our next question, is there an agenda yet for AQO? So we have had our first AQO planning call for congenital, and we got some phenomenal ideas. We have our second call coming up. I don't know, Emily, do we have a date for our second call?
Yeah, we do. It will be at the end of May, and we hope
Okay.
to have a preliminary agenda and initial speaker invitations out by the beginning of June. We'll
Awesome.
post we'll post the agenda on the AQO website, probably at the beginning of June, middle of June, once we have all of that squared away. But we do have like an outline right now of topics that either were submitted via the session proposals, also discussed with the AQO Planning Committee, which is made up of data managers and surgeon leaders for congenital. And we have a lot of good ideas so far, and we're looking forward to the program.
Thank you, Emily. Yep, and next from Dawn. Thank you for the operative mortality abstraction information. I think it must have been under a rock. I've been checking that box only for my index procedure. I do see this in the training manual. No problem, Dawn. Let's see, our next question from Amy. Will there be a networking event at AQO? If so, what day will it be? Since congenital is on Friday, just trying to plan travel hotel accordingly.
We're planning to have it on Thursday evening this year. There will be a
So-
networking event, yes.
Yeah, so get in earlier on Thursday, and we hope to see many of you at that networking event on Thursday evening. Let's see. Mayori, is it possible to obtain from STS summary data on the SSI rates nationally with an average rate for various types of infection? Our institution would like to compare our rate with STS national data. So Mayori, if you want, just email me directly and I can provide you with information on how to request data from the STS national database, that you would submit a request, I believe a minor data request for that. Let's see. All right, let's see. Also, let's see, I'm not seeing any additional questions come in. I don't know if Chastity and Leslie have anything else they want to add. Let's see. Anybody else have any additional, our data requests of Jen, our data requests available again? Yes, so I believe a communication was sent regarding minor data requests out. So if you would like, I believe that communication was sent, I believe, and then also there will be some additional information coming in the STS database news. I think it's coming out at the end of this week. So there'll be more information about data requests being available in database news.
Hey, Leanne, I just wanted to
Yeah.
mention, I checked the training manual. I see some information in the post-op section about coding on index operations or the event most closely related to the complication. But Chas and I were just texting and thinking maybe some additional examples like what we did today would be good. So we'll try to get that in a future training manual.
Perfect, thank you. All right. Again, here's our contact information for those of you that I'm pretty sure everybody knows how to get in touch with us, but again, it's here. If you have any questions about your contract, about your contacts, again, please reach out to us at stsdb_helpdesk@sts.org, and our team, our help desk team can assist with any questions you have about updating your contacts. Again, my email is here, and database operational questions, payments, contract issues, please reach out to us at stsdb@sts.org. And for clinical questions, again, just submit those via the FAQ, the clinical question submission form. So I think that's all that we have for today. I don't see any additional questions coming in. We look forward to seeing you all at AQO. For everyone that's able to join us in person, I hope many of you are able to join us. We look forward to seeing your faces in Nashville. So again, please come see us. We'd love to see you there. Thanks for joining today. Thank you, Chastity and Leslie, for your amazing education. And again, just a reminder, as Emily said, we're having that networking session reception on Thursday evening. So please try and get in earlier and join us at that session. And Chastity and Leslie and I are maybe working on a little something, try and get together with some data managers as well at AQO. So more information coming soon, but again, please arrive early for that Thursday networking session. We'd love to see you all there. So thanks everyone for joining today. I hope you all have a great rest of your week, and we'll see you on our next webinar scheduled for June the 18th. Thanks everyone. I hope you all have a great rest of your week. Chas, Leslie, thank you. And thanks everyone from the STSI for joining today. I appreciate you all.
Yeah, thanks.
Thanks guys.
you.
Thanks,
Bye.
Lynn.
All right. Thanks everyone.